Hi everyone, I would like to present a case about Kathy, a 35-years-old woman who is newly pregnant after having two unexplained miscarriage last year. No tests were done after the losses. Both she and her 38-years-old husband are healthy, but Kathy is now feeling anxious and has turned to a fertility clinic for help. The couple wants to understand what they can do to have a successful pregnancy this time. Several causes are considered. These include genetic factors like chromosomal issue, hormonal problems such as thyroid disorder or PCOS, and uterine abnormalities like fibroids or a septic uterus. We also consider immune conditions like lupus, blood clotting disorder, and chronic infection. Our final hypothesis is rhesus immunization, also known as allo-immunization. This happens when the mother is rhesus negative and the fetus is rhesus positive. The mother's immune system may produce anti-D antibodies that attack the baby's red blood cell, leading to fetal hemolysis and possibly pregnancy loss.
In here, we move on to hematology, where in a rhesus-negative pregnancy with a rhesus-positive fetus, the mother's immune system may produce anti-D IgG antibodies if sensitized to fetus rhesus-positive red blood cells. These antibodies cross the placenta and bind to fetal red blood cells, which leads to the destruction of the fetus red blood cells, causing miscarriage. For genetics, the Rh blood group system is determined by genes on chromosome 1. The genes that encode the rhesus D protein and other rhesus antigens are encoded by the Rhd and Rhce genes, which are 97% identical to each other. Rhesus-positive individuals have Rhd genes and express the D antigen on their red blood cells, while rhesus-negative individuals lack the Rhd gene or have a non-functional variant and therefore they don't express the D antigen. The rhesus-negative status is inherited in an autosomal or recessive fashion, depending on the population, but fundamentally, the absence of Rhd gene causes rhesus negativity. Here is the case study where the mother is rhesus-negative and the father is rhesus-positive, where the fetus can inherit the rhesus-positive gene, which leads to a rhesus-incompatible pregnancy.
In case of immunology, to briefly unpack the mechanism of Rh sensitization, a crucial concept in immunology, especially concerning pregnancy. It begins with the exposure of fetal Rh positive red blood cell. In case of initial exposure and antigen presentation, the most common sources of exposure fetal-maternal hemorrhage, which can occur during the childbirth, miscarriage, and even invasive procedure like amniocentesis, especially fetal Rh positive red blood cell or RBC enter the mother circulation often at the sites where the placenta has been disrupted. Once these foreign Rh positive RBCs are in the maternal system, the immune system springs into action. Antigen presenting cells or APCs, primarily macrophages and dendritic cells, engulf these fetal RBCs, process their D antigen, and then present these D antigen peptides on their MHC class II molecules. This is critical steps for the immune recognition. Helper T cell activation. Now let's move to the helper T cell activation. These APCs with their presented D antigen travels to the lymph nodes. Here they present D antigen to CD4 plus helper T cell. For activation, the T cell receptor on the helper T cell binds to the MHC class II antigen complex, aided by co-stimulation. Once activated, this helper T cell proliferated and provided the essential help through the cytokines like IL-4, IL-5 and IL-6. This help is vital of the next step, B cell activation. In case of B cell activation and initial antibody production with the helper T cell assistance, B cells, specifically those with the receptors for the D antigen, are activated. They then proliferate and differentiate into the plasma cells, which are antibody factories. The initial immune response primarily produce IgM, anti-D antibodies. Importantly, memory B cells are more formed at the stage, setting the stage for the faster and stronger future responses. In case of development of pathogenic anti-D antibodies and secondary responses upon subsequent exposure to Rh positive fetal RBCs are secondary responses. This memory B cell rapidly trigger a much stronger and quicker immune system, a class switch occurs, loading to the predominant products of IgG anti-D antibodies. This is the key because unlike IgM and IgG, antibodies are small and can cross the placenta, posing a risk future Rh positive pregnancies. And then, in the nutshell, the mechanism of Rh sensitization occurs.
Following sensitization, the crucial event is the action of maternal IgG anti-D antibodies. These antibodies have a unique ability to cross the placenta. This active transport occurs via the FcRn receptor on the placenta syncytial trophoblast. Normally, this mechanism is beneficial, transferring protective maternal IgG for fetal passive immunity. However, in Rh incompatibility, this mechanism becomes detrimental, delivering harmful anti-D antibody directly to Rh positive fetus. This transfer typically increases from around 13 weeks of gestation and becomes important during the third trimester. Once in the fetal circulation, this circulating maternal IgG anti-D antibody specifically bind to the D antigens on the surface of fetal Rh positive red blood cells. This process is known as opsonization, essentially tagging these fetal RBCs for destruction. The primary mechanism for this destruction is extravascular hemolysis, which largely takes place within the fetal reticular endothelial system. The main site for this are the fetal spleen, liver, and bone marrow. Here's how it works. Macrophages are phagocytic cells present in the RES, have Fc receptor that recognize and bind to the Fc portion of the antibody-coated fetal RBCs. Once bound, the macrophages engulf and break these tagged RBC inside their cell. This leads to destruction of fetal red blood cells, which can result in conditions like hemolytic disease of fetus and newborn. It's important to note that while complement activation leading to intravascular hemolysis can occur with some antibodies, it's not the primary mechanism for Rh antibodies in this context. The main destructive pathway is the macrophage-mediated extravascular hemolysis.
Hemolytic disease of the fetus and newborn results from Rh incompatibility. It begins when maternal anti-D antibodies, which are IgG, cross the placenta and target Rhd antigens on fetal red blood cells, leading to their destruction. This causes a gradual reduction in fetal hemoglobin and subsequent hypoxia. In response, the fetus experiences an erythropoietin surge, stimulating the bone marrow, liver, and spleen to produce more red blood cells. This condition known as erythroblastosis fetalis. This leads to severe fetal anemia with compensatory efforts by organs like the liver and spleen, potentially causing hepatosplenomegaly and increased cardiac workload. The primary consequence of this destruction is fetal anemia. If severe, it leads to hydrops fetalis, where severe anemia induces heart failure and fluid accumulation in various fetal compartments. In the most severe cases, HDFN can lead to miscarriage or stillbirth, explaining repeated losses in KT. While Rh incompatibility is the main culprit, ABO incompatibility can also cause HDFN. For example, if KT is B and her husband is A, a possible A or AB fetus could be affected. However, ABO incompatibility is typically less severe, often resulting in neonatal jaundice, and less likely to be the primary cause of recurrent miscarriage compared to Rh incompatibility. If the fetus survives, postnatal concerns include neonatal anemia, where persistent maternal anti-D antibodies continue to destroy the newborn Rh-positive red blood cells. This leads to hypoxia, poor perfusion, and symptoms like pale skin and lethargy. Compensatory mechanisms include increased radiculocyte. The other major concern is severe jaundice or hyperbilirubinemia. Excessive hemolysis releases massive unconjugated bilirubin that the newborn immature liver cannot process efficiently. This causes yellow skin and sclera, appearing rapidly within 24 to 48 hours.
Based on the evidence, our final hypothesis is that Rh isoimmunization is the most likely cause of KT's recurrent miscarriages. KT is Rh negative and already has anti-D antibodies in her serum, which means she has been sensitized before. Her husband is Rh positive, so their fetus is likely Rh positive too. This mismatch can cause her antibodies to attack the fetus red blood cells, leading to hemolytic disease of the fetus and newborn, or even miscarriage. To manage this, we focus on 4 main strategies. First, prevention. We can give raw D immunoglobulin, also known as ROGAM, around 28 weeks of pregnancy, and again within 72 hours after delivery or miscarriage, only if the baby is Rh positive. This helps prevent further sensitization. Second, monitoring. KT will need regular blood tests to check anti-D antibody levels. We'll also monitor the fetus through Doppler ultrasound of the middle cerebral artery to detect any signs of fetal anemia. Third, intervention if complications arise. If the fetus is anemic, intrauterine blood transfusion may be needed. If the fetus is in distress, we may consider early delivery. And if the risk is high, amniocentesis can be used to assess fetal bilirubin levels. Lastly, counseling and education. It's important to explain Rh incompatibility clearly to KT and her husband, stress the importance of ROGAM in this and future pregnancies, and discuss possible outcomes, including the need of neonatal care if hemolytic disease occurs.
In conclusion, Kathy's history of recruitment miscarriage is most likely due to Rh isoimmunization, where her Rh negative immune system has been sensitized against Rh positive fetal red blood cells, leading to hemolytic disease of the fetus and newborn. Early identification and management through ROGAM prophylaxis, carefully monitoring of antibody level and fetal well-being, and timely intervention can significantly improve the chances of successful pregnancy. Comprehensive counseling and preventive care remain essential to reduce the risk of future pregnancy loss related to Rh incompatibility.